This is the Fertility Friday podcast, episode number 55. Welcome to the 55th episode of the Fertility Friday podcast. Thank you for joining me today. I'm Lisa from fertilityfriday.com, and this is your source for information about the fertility awareness method and all things fertility. If you've been enjoying the show, I would love it if you take a moment and leave a review and a rating on iTunes. It helps the show to move up in rankings, and it also helps more people to find it. And of course, I'd like to say a special thank you to all the listeners who have left reviews. I do read all of your reviews, and I really appreciate you taking the time to let me know how I'm doing. And if you enjoyed today's episode, please stop by the show notes page and leave a comment. You'll find all the episodes at fertilityfriday.com/podcast, and you can also find me on Facebook at facebook.com/fertilityfridays with an S, and on Twitter at fertilefriday. And as many of you know, I've recently created the Fertility Friday Facebook group. So just go to fertilityfriday.com/community and you'll be redirected to the group where we talk about the fertility awareness method among other women who are also interested in learning or already charting their cycles with fertility awareness. And in today's show, I'm very excited to welcome my guest, Dr. Jerilynn Pryor. Jerilynn is a professor of endocrinology and metabolism at the University of British Columbia. She has spent her career studying menstrual cycles and the effects of the cycle's estrogen and progesterone hormones on women's health. She is the founder and scientific director of the Center for Menstrual Cycle and Ovulation Research. She is also the director of the BC Center of the Canadian Multi-Center Osteoporosis Study that is studying osteoporosis, fractures, and bone density in both women and men. Dr. Pryor has studied women's menstrual cycles, perimenopause, and the causes and treatment of osteoporosis. She is also the author of Estrogen Storm Season, Stories of Perimenopause, and has recently co-authored The Estrogen Errors, Why Progesterone is Better for Women's Health. And in today's show, we'll be talking about the important role that regular ovulation plays not only in a woman's menstrual cycle and her fertility, but also in her overall health in many different ways. And so without further ado, welcome to the show, Jerilynn.
Thank you. Happy to be here.
I'm so glad to have you today. And so, I did give you an introduction, but I would love for you to just share with the listeners what inspired you to focus such a significant portion of your career in the area of menstrual cycle health.
Well, it's interesting because it took me a while to figure that out. I think that I always knew that my interests were very broad and that I was a holistic thinker rather than a very narrow and, drilling down farther and farther into one small spot. But I think looking back on it, that my own experience, which was that my period didn't come at all during my first year at university, I think that affected my curiosity about why that occurred. And luckily, I didn't get sucked into a medicalization system, and my period came back. And once I was done with the stress of medical school, I recovered totally and had kids when I wanted to, and a normal reproductive life. So there was probably something related to that. Also, when I was getting married in the end of just before the start of my third year of medical school, I was desperate to not get pregnant and tried the then Planned Parenthood or, easily available kind of birth control and got very, very ill. In those days, the dose was 100 micrograms of ethinyl estradiol. And I had my first migraine headache. I swelled up like a balloon. And I realized, and this was a peculiar pill, which was taken off the market because it didn't work very well, ironically. I later realized that it was just estrogen that I was taking. 100 micrograms of estrogen was very toxic for me, and therefore all of the positive messages that I got later in my medical school career about estrogen being good and all those positive things for women, I was a skeptic about. So a combination of personal experiences, I think, and my own approach to science and the practice of medicine led me to discover the things I've learned.
Mm-hmm. Well, that's a really interesting experience. And just a random question for reference. Do you know about what the dosage is for the typical pill these days of
Yes,
estrogen?
yes, they're all less than 30 micrograms or less in Canada now, and the more usual is 20.
Okay, so you were having 3 to 5 times the dose that they do
Yes,
now.
a
Wow.
huge dose. But people should realize, although we call them low dose, and they are compared to the pill I tried to take. By the way, I only lasted 5 days on it. It was not good for me. Anyway, the doses in the pills today have to be supraphysiologic, meaning much more than natural, in order to achieve the effects that we want for contraception. So still, the 20 microgram is 4 times our own natural estrogen levels.
Okay. Yeah, that's really interesting because it's crazy to think that you had a dose that was that high compared to what we have now, considering the difficulties that many women have on the pill with the
Today,
dose that
yes.
it's at.
Hmm.
I did want to talk maybe a little bit about the pill, but probably after we talk a little bit about why the menstrual cycle is important. So, as many of my regular listeners would know, one of the topics that I always talk about is why a menstrual cycle is important for overall health and not just important when you want to get pregnant. And I have a quote here from one of your research papers that I was reading online, and it says regular menstrual cycles with consistently normal ovulation during the premenopausal years will prevent osteoporosis, breast cancer, and heart disease in women. And I think that is a very profound and also very kind of alarming statement that it implies what a significant role regular menstruation has in a woman's health. So maybe we could start off by talking about why the menstrual cycle is important.
Well, if you think about it, the hormones of the menstrual cycle are the only way that younger women get estrogen and progesterone. And those hormones are important for our, not only for our reproductive health, but we already know that estrogen works in all kinds of tissues. We've heard lots about estrogen in the brain, estrogen in bones, estrogen in our hearts, and things like that. But wherever estrogen works, progesterone also works. And both together and their balance are what I think is important in preserving our health, not just now, but in the future. In other words, when we're no longer reproductive people, but still have many years of healthy life left.
Mm-hmm. One of the topics that you've written about recently is kind of that myth that if a woman is having a regular menstrual period, if her cycles are quote unquote regular, whatever that means, I know I challenged that concept a bit on the show, but that she's automatically it means that she's ovulating regularly. And so some of the work that you've done has challenged that idea. So did you want to talk a little bit about that?
Yes, let's talk about that because the assumption is, and most of us as women are taught it, that if we have a regular cycle, we can ignore it, everything's fine, no worries, carry on with your life. But the concerning thing is that there can be silent ovulatory disturbances. In other words, a regular cycle does tell us something important, and that is we have enough estrogen. But it doesn't tell us that we have enough progesterone. And the notion that every cycle is ovulatory if it's of a normal length, the so-called normal length, I'm putting quotes in the air here, is 21 to 35 days. And if you can predict, in other words, it's less variable than a week different from in length from cycle to cycle. But I learned a long, long, long time ago that cycles are very variable in the amount of progesterone or post-ovulatory or luteal phase length. So a regular cycle can be normally ovulatory with a normal luteal phase length, which by the the quantitative basal temperature method that I use is 10 days or more. If you're figuring it from the LH peak in the urine, a urine fertility test, then 12 days is the essential normal length of the luteal phase. But a regular cycle can also have ovulation, but a short luteal phase, less than 10 days, which means that you made an egg, but you're not likely to be able to become pregnant and carry that to term, in part because the lining of the uterus needs more progesterone before the fertilized egg can implant. And then finally, and most intense of all, is a regular cycle can just have no ovulation at all. So I had found that in a group of women who were generally lean and who were proven ovulatory, normally ovulatory initially, that very few, like 13 out of 66 women during that year, had some disturbance of ovulation. And yet less than 1% had any abnormal cycle lengths. So I knew that ovulation was highly variable, but it simply wasn't reflected in most of what women could find out about or in the medical literature. So we set off to investigate that in a whole population study in a county in mid-Norway. So this is a fair ways north. It's almost to the Arctic Circle, but it's rather temperate climate because of the Gulf Stream and the warming of the water along the coast there. So what this study did was, in this whole population that was invited to a general health study, the women were already scheduled to have a visit in an investigational center and have a blood test and height and weight measured and things like that. So we asked them before they came into their clinic appointment to keep track of their cycles so they'd be able to tell us how long they were in a single number of days, and also when the date their last flow began. So we simply measured estrogen and progesterone in this. There were more than 3,000, almost 4,000 women. So first of all, we eliminated those women who couldn't say my cycle length is 27 days. And that was 12% of the women. And then there were a few more that had cycle lengths that were usual, that were outside of the normal range. And then we decided that based on what the medical literature had used, and also I did an open-ended question of 5 scientists from around the world, what level of progesterone would you use to decide that ovulation had occurred? And the number we came up with was 9.54 nanomoles per liter, or in the terms that are used in the US, 3 nanograms per milliliter. And we looked at all of the progesterones across the cycle, and together they made the perfect curve of low in the first half of the cycle and high in the second half. And they tended to go up, as we would expect, around day 14, 15 in the cycle. But when we looked at those who were beyond that day 14, 15, and not more than 3 days before their next flow, we found that at least a third of all of those cycles did not have a progesterone level that rose above that progesterone ovulatory threshold.
Okay.
And the interesting thing is that the women in that cycle who ovulated and the women who didn't were basically the same. Same age, same weight, same percentage that had been pregnant. It was like 96 and 94%. So this suggested to me that this was not something that was this group of women never ovulates and this group of women always does, but a variability that was normal. So the women who didn't ovulate in that cycle would probably ovulate in the next.
Okay. And for the women that didn't ovulate, so when you learn the fertility awareness method, you do learn that you learn how to tell if you've ovulated, like you said, with the temperature method. And so these women were having what we'd call anovulatory cycles. Is that right? And they would still have menstrual bleeding of some kind.
Yes, either that, either they didn't release an egg, anovulatory, or they had a short luteal phase. So, in other words, we might have caught them on day 15, but they actually didn't ovulate until till day 17.
Okay.
Do you understand? In other words, we had to use population data to decide where to take our window for presumed ovulatory cycles.
Okay.
So they could have had short luteal phases as well.
Okay. Well, and that's really interesting. You know, a lot of the listeners to this podcast are trying to get pregnant. And so many of the listeners know this, to some extent, the significance of a short luteal phase in terms of your fertility. So understanding that the short luteal phase means that there's not enough time for the egg to implant. But maybe we could talk a little bit about why progesterone is important. So, because obviously, in your study, you were quantifiably checking to see how much progesterone these women had in each cycle. And so obviously you're not going to study something unless it is important and significant in terms of a woman's health.
What's interesting is that it hasn't been considered important, so there's very little research about it. That was the first large population-based study that had ever asked that question.
Mm-hmm.
And when I tried to get it published in the general medical journals, the universal response was it belonged in a specialty journal. And I finally got quite annoyed. One of the editors happened to be a woman. And I said, wait a minute, how can this belong in a specialty journal? If I were writing that a third of men were infertile at any one point in time, that would be a public health emergency, right?
Yep.
And it should be considered in the same way for in the data related to women. It's crazy how women's cycles are put in a particular bin as though they're only relevant to whether we want to get pregnant or not.
Well, and I think that's what I appreciate and find most interesting about the work that you've done, because your focus isn't on why this is important for fertility. Your focus is definitely what health markers are impacted by a woman's menstrual cycle,
Mm-hmm.
which I think is so important because as women, we're not taught about our menstrual cycle, and we're basically taught that we can throw away, in a way, ignore our
Mm-hmm.
menstruation by
Mm-hmm.
taking hormonal contraceptives that stop it, because we're told that unless you're trying to get pregnant, it doesn't matter if you're
That's right.
menstruating.
Yeah. It's
So,
crazy. Can you imagine if men decide to suppress their testosterone? I mean, that would immediately be something they would understand was not a good idea, because they all know that testosterone is important for libido and muscles and bone and virility and all that stuff. Well, it's
mhm.
similar in women. I mean, we need these hormones during our reproductive years.
Mhm. Well, absolutely. And so these women then in the study who either weren't ovulating or had low progesterone levels and had short luteal phases, what are the health implications of not having regular ovulatory cycles and not having sufficient progesterone?
Okay, the one that we're most sure about is that you need both estrogen and progesterone for optimal bone health. So let me explain that a bit. The initial study that I did, I referred to it briefly before, about the 66 women who were healthy and normally ovulatory. They kept regular cycles during the majority of them were stayed healthy, stayed the same weight during a year. Some of them were just normally active. They'd play a game of squash or some tennis or take the kids on a bike ride or something on the weekend. Others were running, but for fitness and health, not for competition. And there were some women who were training for a marathon. The reason I did that study was because I got rather annoyed that everyone assumed that exercise would be bad for women's cycles
Mm.
and bad for bones. So I wanted to find a real world situation and observe what happened. At any rate, during that study, the cycles and ovulation were the same, whether they were basically sedentary, whether they were fitness related runners, or whether they were training and increasing their running in order to run a marathon.
Mm.
So we had a group of women for whom we had regular cycles, but the thing that varied was the luteal phase length. And we discovered that there was a tight connection between the overall length of the luteal phase during that year, the average, and the change in bone during that year. And that was also kind of a fluke because this was before the common bone scans that we all have today. And so we were using a CT scanner to look at the inside of the vertebral bodies. So that's a very rapidly turning over bone. And what we showed was the 13 women during that study who had at least one cycle where they didn't ovulate were losing 4% of their spinal bone. The women who had multiple short luteal phases were losing about 2% a year. And those who had one short luteal phase or only ovulatory cycles were staying about the same. So that said that 20% of the change in bone during that year was related to progesterone and the amount of progesterone as reflected by the length of the luteal phase. So that's how I got started working on progesterone and bone.
Well, that's pretty incredible because because when it comes to bone loss, we're just told to drink our milk and exercise.
Right. Yeah, and that's part of the message, but not the whole message. If people are interested on the SEMCOR website, which is www.cemcor.ca, Center for Menstrual Cycle and Ovulation Research. If you look under bone health or osteoporosis, you'll find ABCs of osteoporosis prevention for teenagers, for premenopausal, for midlife, and for menopausal women. So take a look if you're interested. At any rate, so what happened was there were others who decided that we were wrong and that they would prove we were wrong in this observation. Everybody knows estrogen's important for bone, but progesterone, who ever heard of that? At any rate, so there were, over the years, there have been several other studies, and we were eventually able to find 6 studies that had both measured change in bone and ovulatory characteristics, cycles and ovulatory characteristics. And that showed if you took all the studies together and within each study you said, which women in this study have the majority of their cycles with normal ovulation, which have the majority of their cycles with less normal ovulation, or short luteal phase or anovulation. And if you do that, there's what's called a weighted mean difference of almost 1% loss in those with the less good ovulatory characteristics.
Hmm.
So this meta-analysis was published in Epidemiologic Reviews in 2014, and it's open access now.
Mm-hmm. Well, I think what is interesting about the study that you were talking about is that it's not only if you're not ovulating that your bone status is
Mm-hmm.
impacted. It's also if you are ovulating, but if you have a short luteal phase.
That's right.
So showing that and the short luteal phase is basically some form of, it's related to having insufficient progesterone in your cycle.
That's right.
Because one of the things you mentioned at the beginning of the show was the importance of having a balance of estrogen and progesterone.
That's right.
And so that's why in a healthy cycle, you have about half the cycle would be the pre-ovulatory phase, and about half the cycle would be the post-ovulatory estrogen,
Mm-hmm.
progesterone.
So let me explain just briefly so people will understand. What what I understand about how progesterone relates to bone is that it actually directly stimulates the osteoblast cells that build bone. When progesterone is around, there are more osteoblasts that are available, and they make more of the protein matrix or the osteoid that then gets mineralized and becomes bone. So it's a direct effect on bone formation. And progesterone, in contrast to estrogen, doesn't slow down bone loss. So what was happening to women with a regular cycle length is you all know that estrogen rises to a peak, drops a bit, and then a second peak during the luteal phase. Well, then it drops to a low level. And that low level is actually similar to the level during menopause. So the drop from a high mid-cycle peak down to that low causes a little bit of increased bone resorption, which means that you need the formation stimulation of progesterone to be in balance.
Okay, so just in a regular menstrual cycle, because there's a drop in estrogen, that drop in estrogen causes some degree of bone loss.
That's right.
And so then you need the progesterone because progesterone stimulates bone formation, and that balances it out so that you're not really losing any bone.
That's correct. Yep.
Fascinating.
Yeah, it is. It is. And it took me a long time to sort of understand what was going on. It was a long time before we could show that there was some slight increased bone resorption that occurred usually in the early part of the cycle following the period.
So now I have a burning question. So,
Okay.
if a woman is on the birth control pill or another type of hormonal contraception that is introducing synthetic estrogens and progestins into her body, but because it's suppressing ovulation, then her body is, if she's producing progesterone, it's probably not very much at all.
That's right.
So, what is the impact of that on bone loss?
Well, that's a super important question, and it's one that's controversial. So that you can find studies in the literature, most of them are ones that took menopausal women and they asked them, were you ever on the pill? And were you never on the pill? And then they would say, oh, if you were on the pill, you have a higher bone density. Well, that's a very poor study because it's confounded. Women who use the pill, at least in the past, were more likely to use menopausal hormone therapy as well. But at any rate, the few studies that we have that have studied women in their sort of mid-reproductive lives, let's say from 25 to 35 or so, the pill doesn't seem to change bone at all. It seems to be neither good nor bad. So that's good.
Mm-hmm.
But and this is new, it hasn't hit the consciousness of the general public yet, is that if a woman starts the pill when she's still growing bone, when she's a teenager, that there may be negative effects on her bone density. And that is super important because the way bone works is we build a strong skeleton and achieve a peak bone mass. Some for the hip sites, it's in our late teens. For the spine, it's later in our 20 or 30s. And that's as much bone as we'll ever have. The rest of our life, we either hold it steady or we begin losing it. So it's important to build a strong peak bone mass. And I think that young women who use the pill, especially if they use it before they've established normal ovulation, may have difficulty achieving a normal peak bone mass and may be at risk for osteoporosis later.
Well, how long does it take then for a young woman's menstrual cycle to develop and mature? So obviously this is going to be different, person to person, but
Right.
from your experience and from your research, about what age does a woman reach that peak bone density or bone mass?
Well, the peak for bone in the hip is in the late teens. The peak for the spine is in the 30s. But the menstrual cycle, the maturation of the normal menstrual cycle takes on average about 10 years, maybe 12 years after the first period, after menarche.
Okay, well, that has significant implications because most women who take hormonal birth control, it's safe to say that they're taking it before they're 30. And you mentioned that that's when our spinal uh,
That's right.
column is at peak bone density, and
Yep,
many are taking it in their teens, which is also before the hip peak formation. So
that's right.
that's a scary thought.
It is. And increasingly I think that birth control pill is being used for treatment in the teen years. In fact, I'm working on a paper right now about that. We have data from the population-based Canadian multi-center osteoporosis study that studied women and men from St. John's, Newfoundland to Vancouver, in other words, all the way across Canada. And what we're seeing is that the average age at starting the pill in those who are in their teens still is in the late is like 16 and a half. In if they're 20 to 24, the average age is like 18. But in the adult cohort that was somewhat earlier, the average age at starting was almost 20. So we seem to be using the pill at younger and younger ages. And in the teen years, more than half, according to the CAMOS data, are using the pill for treatment, like of something like cramps or irregular periods or skipped periods or heavy flow or acne.
Maybe you could take a moment to talk a little bit about the maturation process because when a young woman begins menstruation, most women don't begin menstruation with these perfect 28-day
Sure.
regular cycles where everything's amazing. There, as you mentioned, it takes
Yep.
up to 12 years for full cycle maturation.
Yes. The typical thing is that cycles are long initially, and they may continue to be irregular, meaning varying more than a week from cycle to cycle for a number of years. Um, what takes the longest to develop is precisely the most finely tuned of our reproduction, which is ovulation. And that's what appears to take almost 12 years.
Wow. Well, and so the very thing, one of the things that they are quote unquote treating, which obviously is not being treated, it's being masked uh,
Yes,
by the
yeah,
pill, is then preventing the cycle maturation. Because, this is a topic that I've talked about with a number of guests on the show. And if the cycle doesn't fully mature and you go on the pill for 10 years, you go off the pill, your cycle has to finish maturing.
that's right. And it seems to have a more difficult time doing it later on. I don't I don't know, and nobody's proven that, but that was my clinical experience.
Hmm.
That there's a window of opportunity, if you will, for the bone to grow to its peak, and there's also a window of opportunity for the cycle to mature to its optimal.
Hmm. Well, and to kind of close out our talk about the birth control pill, because I know we could talk about it all day. I could always talk about hormonal contraceptives. You tend to bash them a lot on the show, unfortunately, or fortunately, depending on your perspective.
By the way, I want to remind your listeners to take a look at the SEMCOR site about contraceptive choices, because what I've done there is to say we now have the opportunity to choose a reliable form of contraception that doesn't interfere with ovulation. And there's several of them, but the one that is new is the copper IUD.
Hmm.
And so it's not messing with our hormones and it's providing reliable contraception. And if you get cramps, which many do, ibuprofen, and again, you can look up cramps on the SEMCOR site, effectively deals with bad cramps.
Hmm. Well, yes, it's so important for women to know that you don't only have one option. Hormonal contraceptives are one option, and it's important to know what they're doing in your body. Um, the IUD that does not, the copper IUD that does not have hormones is also an option. And of course, fertility awareness, because that's what I'm always talking about. But one of the things, there's obviously different types of hormonal contraceptives with varying dosages of the synthetic estrogens and progestins.
Mm-hmm.
But many women notice particular side effects when they use the injectables, so Depo-Provera.
Mm-hmm.
So, and also Depo-Provera has been discussed specifically with respect to bone loss. So, do you have any thoughts on Depo-Provera and why it seems to be impacting bone in such a significant way?
Yes, and I have a good news story about that as well. So, Depo-Provera is high-dose medroxyprogesterone, which is a synthetic progestin. And it's such a high dose. For example, if I were going to give a equivalent to the luteal phase, I would use 10 milligrams. The dose that's used for contraception as an injection is 150 milligrams, and that lasts for 3 months. So it's such a high dose that it suppresses the hypothalamus in the brain and the pituitary, causing our own estrogen levels to drop almost to menopausal levels. Well, we
Mm-hmm.
talked before, whenever estrogen levels drop, there's an increase in bone loss. And so that's the reason that there's bone loss, especially in the first 2 years when someone starts Depo-Provera. But the good news is that, and this is from a collection of all of the data in the literature, when we stop that Depo-Provera shot, usually we recover cycles and ovulation, and there's remarkable increase in bone to at least as high as it was before, and often to higher.
Mm-hmm.
So even in teenagers now, I think most people will agree that those women regain all of the bone that they lost.
Wow. Well, that's good news. It's scary how dramatic that is, and it's very interesting how it indirectly impacts the bone by
Mm-hmm.
suppressing the estrogen levels. That's really interesting. And I've had a number of women asking about the IUD that does have the lower dose of hormones. So have you come across that in your, like, a lot of women
Yes.
use that because they feel that it's a better option because they're getting less of the hormone dose.
Yes, it's quite true that it's less likely to alter ovulatory cycles. But you know what bothers me is that no one has properly studied that.
Hmm. So even though it's a lower dose, it hasn't fully been studied in terms of the impacts that it has.
On ovulation over time, it generally doesn't change the cycle length, or I mean, it actually decreases the bleeding because it's thinning the lining of the uterus, so there's less to shed. But what it does to ovulation, we don't know.
Hmm. Okay. And then the copper IUD works but it doesn't disrupt the normal ovulation. So it means that
No.
the woman could, because I know a lot of, a lot of people in general are concerned about how or how contraceptives work, pardon me. And so and it wouldn't be for everyone, because I know there's a portion of the population that definitely is concerned by the fact that you could be conceiving technically,
Yep.
and then the IUD is then preventing implantation, that type of thing.
Mm-hmm. Mm-hmm.
So to switch gears a little bit, we've talked a lot about the impact of regular ovulation on bone health. And in your research, you have also talked about the impact of regular ovulation on heart health and breast health. So
Mm-hmm.
maybe we could talk a little bit about why regular ovulation is important for heart health.
Okay, so I think we don't totally know the why of that yet, but I did a study in which menopausal women were given either progesterone or a placebo. It was actually a treatment study for hot flushes, and it showed progesterone is good at treating hot flushes. But in that study, I enrolled women who had no risks for heart disease. So they were early in menopause. They didn't have high blood pressure or diabetes or abnormal cholesterol. In general, they weren't extremely overweight or obese. So we enrolled healthy women in terms of the heart, and then we could study what happened when they started progesterone and took it for 3 months. And we could compare that with whatever changes occurred on the placebo over 3 months. Well, one of the most important parts of that study was to look at what's called endothelial function. It's the mechanism that our blood vessels use for dilating, getting larger and increasing flow, or constricting. And those are complex, nitric oxide related. But it turns out that progesterone is as good as estrogen, and perhaps even better at increasing the blood flow, which is a fundamental characteristic of a healthy cardiovascular and heart system. So we know that progesterone works in the endothelial system. The good news is that in these healthy women, there were no changes in weight, systolic or diastolic blood pressure, in waist circumference, in fasting blood sugar, in cholesterol measures, in inflammation, or in blood clotting. The only thing that changed, and that was a very small decrease in the high density cholesterol, HDL cholesterol. The change was small enough that it didn't alter a standard profile looking at women's risk that uses that in the profile. So it's probably a subclinical change, not important for heart. So we know that that progesterone is safe in healthy women in terms of cardiovascular risk factors. Okay, but I began to think about the heart and progesterone from a very interesting study that was done in Georgia in what are called cynomolgus monkeys, tiny little monkeys that have a reproductive system that's very similar to women's. And these monkeys were in captivity. They were in so-called family groups where there would be 3 or 4 females and one male that had been vasectomized. So it couldn't make the females pregnant, but it had normal hormonal function. So what the investigators did was to have the female monkeys go through a little sort of tunnel. So they were kind of trapped for a minute, and they took their temperature and they swabbed the vagina to see if there was any bleeding, because they do have a little bit of a period. And they weighed them and looked at all the other characteristics. And after about 3 years, all of the monkeys had were sacrificed and had the arteries looked at. So all of these monkeys, it turns out, were on a really high-fat diet, sort of the Big Mac 3 times a day kind of diet, and rather than the usual nearly vegetarian monkey diet. And so there was a lot of plaque in the arteries, especially of the male monkeys. Plaque is what leads to heart attacks. But what was interesting is that there were basically two groups of the female monkeys. Turns out that in these family groups, there's one or maybe two of the females that are the big boss. And they get all the grooming. They react angrily if one of the inferior monkeys gets to the food first, and so they shoo them away. In other words, there's a hierarchy.
Mm-hmm.
The monkeys that are subordinate are stressed. And it turns out that those stressed monkeys, though they weighed the same and had the same cycle lengths, were less likely to ovulate. And when they came to look at their arteries showed similar kinds of plaque and evidence of vascular disease as those of the males. But the monkeys that were dominant, that were confident and in charge of their lives, those female monkeys that ovulated normally had normal looking arteries. So that's what got me to thinking progesterone must be needed for normal heart function as well.
Mm-hmm. Yeah, that's really interesting. So then the implication is that if a woman isn't ovulating regularly, or even if she is ovulating again with the short luteal phase, that can be negatively impacting her heart health.
That's right. And because, well, first of all, we know that women start having heart attacks on average 10 years later than men. And for years, we've been saying that's because they have estrogen. Estrogen's what's good for the heart. But what I believe is that you need both estrogen and progesterone to be protected from heart disease.
Mm-hmm. Okay, and then what is the connection between regular ovulation and breast health?
Okay, there were in the old days, years ago in the 80s or maybe earlier, there were some big studies that well, in one, in fact, was in women who had hormone related infertility. And they showed that these women had a higher risk for breast cancer compared to the general population. And another study looked at women who had PCOS, polycystic ovary kind of syndrome, and they followed them and found they had both more endometrial and also breast cancer than other women followed for other conditions over the same duration of time. But on that sort of idea that ovulation disturbances were related to breast cancer sort of got lost when we realized that estrogen with progestins increased the risk of breast cancer more than estrogen alone.
Mm.
And so it took until we had natural progesterone as a therapy, and France was the first country to have it as a therapy, and a big study in France that kind of like a teachers union, and they all had insurance through that union, and thousands of those women agreed to be in a study where they were just observed. So what has happened now is they've been able to follow about 80,000 women for more than 8 years. And these were menopausal women, and they simply asked them, did you ever take menopausal hormone therapy? And those who said no were the controls. Those who said, yes, I took estrogen, were found to have a 29% increased breast cancer risk. Those who took estrogen with progestins, like medroxyprogesterone, had a 69% increased breast cancer risk compared to those not treated at all. But those who took estrogen with progesterone, the native hormone, had no increased risk. And that's now been repeated in a population-based study from France as well. And here's how I think it works. Estrogen's job, whenever it sits on receptors where whatever tissue it's in, is to make that tissue grow. And proliferation, if it's unchecked, is one of the risk factors for breast cancer. But progesterone's job, after a short time of initial growth, is to make that tissue more mature, more grown up, which is against breast cancer risk. So if you have enough progesterone to counterbalance the growth effects of estrogen, then breast, like other tissue, is not at risk. But if you don't, then there may be some overgrowth that eventually leads to malignancy.
Again, fascinating.
Yeah, it is. It is. And there was just a study this summer. I don't know why I'm always in such controversial areas, but this is very controversial. But this summer, some investigators from Australia discovered that the progesterone receptor, it's stimulated by progesterone and progesterone acts there, makes the estrogen receptor in breast cells change from causing cell proliferation into causing cell maturation. In other words, what I was just telling you in general has now been shown, and we have a mechanism for it in the human breast. So I think there's a wide open opportunity if only we could start clearly documenting ovulation in large groups of the population to both show the connections that I've been looking at between heart health and ovulation and breast health and ovulation. The problem is that most women are not, like, as I gather your listeners are, tuned into their own bodies. They're not paying attention to things like temperature and mid-cycle mucus and things that change across the cycle, so they don't have a clue if they're ovulating or not.
And I would add that no one has ever told them why that's important, why it would even matter if you're ovulating regularly.
That's right. Yes.
Well,
That,
and oh, sorry, go ahead.
no, it's fundamental that women learn that estrogen and progesterone are important. They make us healthy and who we are, along with our environment and our heredity and all of the rest of that, and that they're something precious, that they're modulated by the stresses of our environment and how we react to them. And they're modulated by things like illness or not eating enough to cover the amount of energy that we're spending. That this is so important. It's the ABCs of taking care of ourselves.
Yeah, absolutely. And for women who have started charting their cycles, I always say that that's one of the unexpected effects of that. When you're actually monitoring your menstrual cycles, you start to see, just like you said, how our cycles are impacted by stress levels, travel, eating habits, various
Yes.
life events. And it's really fascinating actually to be able to see that in real time, how your cycle is affected by these things. And when you were talking about the role of estrogen and progesterone, estrogen being growth and progesterone being the maturation, I couldn't help but think of the menstruation part of the menstrual cycle, where in the first part of the cycle, estrogen is causing that uterine lining to grow.
Yep.
And then in the second half of the cycle, progesterone helps that uterine lining to mature so that you're ready to actually implant a baby.
Mm-hmm.
And
Exactly.
yeah, and that has so many implications, what you said in different ways. Again, I would have a lot of questions. I don't know if I'd be doing a lot of research, but I certainly would be able to come up with a lot of research questions. And one of them would be, if a woman is on hormonal contraceptives and she's not having any progesterone really, then what's happening to her uterine lining? Because it's is it growing? Is it maturing, or what's going on in there?
Well, it's sort of in a stunned state. It's most of the pills are higher in estrogen than they are in progestin, and therefore there's enough progestin to stop the risk of endometrial cancer, but there's not enough to prevent the full growth, which is why you get a period.
Hmm. Yeah, no, these are very, very interesting questions. And so we've talked a lot about ovulatory disturbances. So as we gear towards the end of our interview, what are some of the causes of ovulation disturbances? And maybe we could spend a little bit of time talking about what we can do to try to foster more regular ovulation.
Okay, very good. When I try to explain it to patients, I think the key thing that makes for normal ovulation is feeling at home with yourself. That means, what your abilities are, your community, your family, those who love you, and with expectations for the future. So that internal sense of I'm good, I have possibilities, you know, I can't explain it very well, but that sense of self-worth is key to normal ovulation. And the things that disrupt that are things that cause disturbances of ovulation.
Hmm. Could you elaborate on that a little bit?
So for example, if I'm really stressed, then I don't eat as well, I don't sleep as well, and if I were still a menstruating woman, I would probably have a short luteal phase.
Hmm.
So when we realize that when we're stressed, that we react in these ways, then we can make an extra effort to eat healthily, to get time enough for sleep, to learn, and I think this is the most important of all, is to learn relaxation, mindfulness meditation, yoga breathing, or some technique that allows us to center ourselves, to calm ourselves fundamentally. And when we do that, then our body can heal itself.
Hmm. I think a lot of people, myself included from time to time, don't really consider the detrimental impact that stress has on our lives and on our health and on our bodies. It's so easy to say, "Oh, stress, relax, reduce your stress," but it's a thing, and it's really important. It plays a really important role. It was really interesting in the study you were talking about with the monkeys of how stress levels were what was kind of disrupting their ovulatory cycles.
Yes, for sure.
Hmm.
For sure. And although the most common reason I think today is not eating enough to cover our calories. In other words, kind of, I'm too fat, or that kind of a inappropriate concept that if I restrict what I eat, then I will be more in control and I'm not going to gain weight, or I'll gain some sense of self-worth by being thinner. Those ideas and not eating enough for our needs are key to ovulation, and often the common pathway through which ovulatory disturbances occur.
Hmm. And I would throw in that arguably when we do eat, we may not be eating foods that have high degrees of nutrition.
That's right. Sweet stuff that makes us feel comforted for the moment.
Hmm.
Yep. Yep.
Well, I have a few final questions to end the show with. So, what would you say is the biggest myth about fertility that you would like to see corrected?
Hmm. Well, the biggest myth is that regular cycles are always ovulatory.
Hmm. And what would you say is the biggest myth about women's health?
that estrogen is the one that's responsible for making us feminine, sexy, all those, lovely, all those positive attributes we give to estrogen really belong to both estrogen and progesterone.
Mm-hmm. What would you say is the most important thing that a woman should know if she's trying to get pregnant?
The most important thing is to believe that you can, and that the power is within your body, and you don't have to rely on someone else, at least at the first instance. So believing that you will be able to get pregnant is 90% of the issue with infertility that relates to ovulation disturbance. When we don't feel like we can, or we feel threatened in that role as women, then an ovulation occurs and it sets off a vicious cycle.
Okay, and final question of the day. For a woman listening who is currently on the pill, she doesn't want to get pregnant right now, but she is thinking about pregnancy, say, in the next 2 to 3 years. What advice, if any, would you give to her?
My advice would be to stop the pill, to start charting her own cycles, learning about not only the changes that occur in in what she's experiencing, but also in her temperature. And by the way, there are free online diaries and also the quantitative basal temperature method on the SEMCOR site. So I would encourage her to use these 2 years to get to normal ovulation. So when she wants to get pregnant, she'll be able to.
I think that's a wonderful note to end on today. So, Jerilynn, I'd like to thank you so much for taking the time to be here today and sharing your knowledge and your wisdom and your experience with our audience. And I know you've talked about the SIMCOR website, so I'll definitely link to that in the show notes page, as well as a few of the articles that detail some of the important information we were talking about today. Did you want to give the listeners any other ways to contact you if they have questions or just to learn more?
There's a SEMCOR info place where women can email in questions, and I'll do my very best to answer. And thank you very much, Lisa, for spending this time with me and letting me share some of the things I've learned.
Oh, it was absolutely my pleasure to learn from you today. I was taking notes like crazy, and I just really appreciate you for the work that you're doing. You're the pioneer in this area, and it's incredible, as you said, that no one is making these connections. So I think we're all thankful that you're doing this important work.
Thank you.
Thank you for listening. If you enjoyed today's show, please share it with a friend. I'd love to hear your thoughts on today's episode. So much important information about the impact of our menstrual cycle on bone health, heart health, breast health, overall health. So I'd love to hear your thoughts. So head over to fertilityfriday.com/55, so the number 55, and let me know what you found most helpful or most surprising from today's episode. You can also find me on Facebook at facebook.com/fertilityfridays with an S. You can find me on Twitter at Fertile Friday. And you can also head over to the Fertility Friday Facebook group at fertilityfriday.com/community, and you'll be redirected. And if you've been enjoying the podcast, please look for it on iTunes and leave a 5-star review so that more people can find it. If you have an idea for a podcast episode or a guest suggestion, just shoot me an email at info@fertilityfriday.com. And once again, I appreciate all of you for taking the time to tune in to the podcast. Thank you so much for your support for the show and for listening in. And as always, until next time, be well and happy charting.